In the continuation of infectious medicine, today I will discuss HIV and AIDS. So first of all, we should know that what is HIV. HIV is a virus which attack our immune system. So most commonly, it affects which cells in the body? It affects the CD4 T lymphocytes, right? HIV affect CD4 T lymphocytes. Once it affects T lymphocytes, resulting there is CD4 T cell destruction. When CD4 T cell destruction occur, it lead to AIDS. AIDS is acquired immunodeficiency syndrome, and this AIDS occur when the CD4 count it is less than 200. When AIDS occur when CD4 count it is less than 200, while the normal CD4 count is, yes, the normally CD4 count is from 500 to 1500, but in case of AIDS the CD4 count is, yes, less than 200. Now what are the types of HIV? There are two types of HIV, HIV 1 and HIV 2. Now HIV 1 it is most common worldwide, but if I talk about HIV 2, this HIV 2 it is most commonly it is present in the West Africans, and HIV 1 is most common. HIV 1 is most common, while HIV 2 it is commonly it is present in the West Africans, and it has a slow disease of progression. Now most commonly HIV it is spread through sexual route. The most common route of transmission is sexual route, or by sharing needles, or by needle stick injury, and vertical transmission. Vertical transmission means the diseases get transmitted from mother to fetus, while the most common mode of transmission is sexual route. Let's talk about clinical features. So there are three different stages for HIV. While the first is there is acute infection. In acute infection, the patient acquired this infection and develop acutely symptoms, while in another phase the CD4 count, when CD4 count it is less than 500, so in that condition the patient develop illness, but that illness are not AIDS defining illness, right? It's important. But if in another phase, if the CD4 count it is less than 200, so in that condition the patient that develop illness that are AIDS defining illness. So let's discuss in the first phase. In acute infection, usually the patient is presented with fever, fatigue, there might be malaise, yes, myalgia or arthralgia. Now if you see all these symptoms, they are just like infectious mononucleosis. So in this way it's so very difficult to pick up this disease. While other than that, there might be non-tender lymphadenopathy. There might be non-tender lymphadenopathy. There might be generalized maculopapular rashes. Now in stage 2, there is when the CD4 count is less than 500. So in that condition, what are the presentations? There might be persistent chronic lymphadenopathy, and there is chronic diarrhea and oral candidiasis and warts. So keep in mind that oral candidiasis is occur when the CD4 count is less than 500, but esophageal candidiasis occur when the CD4 count is less than 200. So and there is warts as well. Now if I talk about CD4 count, if it is less than 200, and pneumocystis and Pneumocystis pneumonia. And if the CD4 count it is less than 100, so it is cerebral toxoplasmosis, cryptococcus meningitis, esophageal candidiasis, less than 100 in cerebral toxoplasmosis, cryptococcus meningitis, and esophageal candidiasis. If the CD4 count is less than 50, that is a disseminated MAC, Mycobacterium avium complex, and cytomegalovirus that cause the retinitis or that cause colitis. Right? So I repeat, if in acute infection there will be fever, fatigue, malaise, myalgia, arthralgia, there might be non-tender lymph adenopathy. But in case of if the CD4 count is less than 500, there will be temperature, orocandidiasis, chronic diarrhea. But if the CD4 count is less than 200, that is an Pneumocystis pneumonia. CD4 count is less than 100 and cerebral toxoplasmosis, cryptococcus meningitis, and esophageal candidiasis. CD4 count is less than 50 and disseminated MAC. Now, there are some screening tests and some are confirmatory tests. So, what is the screening test? Screening is done with fourth generation antigen antibody assay. Right? Screening is done with fourth generation antigen antibody assay. Basically, this antigen antibody assay it detects both antigen and antibody. Now it detects both antigen and antibody, and the antigen in the form of HIV P24 antigen and HIV antibody assay, that is in the form of IgG and IgM. But the most important and initial test for the HIV, that is ELISA. But always keep in mind that ELISA it always detect antibody, it does not detect antigen. Right? Now, if the fourth generation and if the fourth generation antigen antibody assay, if these tests becomes positive, if these tests become positive, so do HIV 1 and 2 antibody differentiation assay. So if these tests become positive, so we have to do HIV 1 and 2 antibody assay. Basically, this test it detects the types of virus, and it is considered as the most confirmatory test for the HIV. If this HIV 1 and 2 antibody differentiation assay, if it become positive, so it means that HIV is positive and the patient is a diseased person. If the disease is negative, if the test is negative, so it means the patient has no HIV. But if the test is negative and you are in high suspicious plasma HIV RNA testing, then we can do plasma HIV RNA testing. Screening in infants. Now, do not use antibody test. Do not use antibody test in case of infants because of maternal antibody. The test may be false positive. Because of maternal antibody, the test become maybe false positive. If the mother is infected with HIV and you want to inspect the baby that whether that is affected or not, so you can't do antibody test because the IgG can cross placenta, and even if there is no HIV in patient, so the antibody may be detected in the blood. So in that condition you can't do the antibody test, rather you can do another test, that is HIV 1 RNA testing, PCR or NAT, nucleic acid amplification test or PCR for HIV. Now, before treatment, you should know the mechanism of action of antiretroviral drugs. So let's suppose if this is CD4 T lymphocyte cell, so over CD4 T cell there are two receptors, and this receptor is CN2CR4 and CCR5, right? So what happens on the surface of CD4 T lymphocyte, there are CN2CR4 receptor and CCR5 receptor. So what happens, this HIV, it enters it HIV, it binds to the receptor and it comes into the cell. Now soon as when HIV reach into the cell, it converts the viral RNA into viral DNA through the specific enzyme, and that enzyme is called as, that is reverse transcriptase enzyme. The viral RNA become converted into viral DNA. Now this viral DNA, it reached to the nucleus. It integrated in the nucleus and it forms the RNA copies, right? These RNA copies, it forms the different proteins. Now RNA copies and proteins, they get assembled and released from the cell through the specific enzymes, and that enzyme is called as proteases. So the proteases are responsible to release the proteins, and that is different RNA copies and proteins outside the CD4 cell to the another adjacent cell. NRTI and NNRTI, that is nucleoside reverse transcriptase 1 and non-nucleoside reverse transcriptase 1. These antiretroviral drugs, basically it block the reverse transcriptase, right? These two drugs, it block the reverse transcriptase. Protease inhibitors. So protease inhibitors, what it do? Protease inhibitor, it inhibit the proteases. It inhibit these proteases, right? That is integrase inhibitors. Now what these integrase inhibitors do? These integrase inhibitors, it inhibit the viral DNA and inhibit the integration of viral DNA in the nucleus. Antiretroviral therapy. Now it consists of an antiretroviral therapy. We have 2 NRTI plus 1 NNRTI. Here we have 2 NRTI and 1 PI, protease inhibitors, and that is also called as boosted therapy. Or we have 2 NRTI plus, that is INI, integrase inhibitors. So what is 2021 CDC guideline? So in this guideline there is 2 NRTIs and 1 consists of INI. So in 2 NRTI, it consists of tenofovir and emtricitabine, right? So in 2 NRTI there is tenofovir and emtricitabine, and 1 INI is consist of bictegravir. While the dose for the tenofovir, that is 25 mg per orally daily, and for the emtricitabine, that is 200 mg per orally OD. Now other than that, we can also give 2 NRTI and INI, and 2 NRTI we can give the Immunodeficiency and the dose of 600 mg per orally OD, and we can go lamivudine in the dose of 300 mg per orally OD. While in INI it consists of dolutegravir with the dose of 50 mg per orally OD. Now, this all formulation, it comes in the triumic with the 1 tablet daily. Now this triumic, it may be used in pregnancy, but it is contraindication in HLA-B positive. So there are also, we can use 2 drugs combination in INRTI and I1 INI, and that is consists of in INRTI it consists of limivudine, while in one INI it consists of dolutegravir, while combinedly it comes in the formulation of Dovato. If someone need a stick injury with infected HIV patient, then at that condition you have to give what? Tenofovir plus imcitrabine with altegravir. Give tenofovir in the dose of 300 mg per orally OD and imcitrabine with the 200 mg per orally OD and reltigravir with the 400 mg per orally, and it is given for the 4 weeks. And post prophylaxis patient, it should given within 72 hours of exposure. Now, if there is HIV in pregnancy, so always keep in mind the drug of choice is zidovudine. So zidovudine is the drug of choice in case of pregnancy, plus with 2 other corticosteroids. Efavirenz is the only antiretroviral drug which is contraindicated in pregnancy.